question, and so this is my question. So no judgment on any participants. They didn't send in this question, so I just want to make sure that we're all kind of understanding some basics at the beginning. So, Dr. Taneja, you mentioned that you're a movement disorder specialist. You guys are in the industry representing each of the 3 companies that are currently FDA approved. But I feel like there's one more person that sort of would complete the cycle of those who would be involved, and that would be a neurosurgeon. Is that fair?
That's
okay.
Correct.
So maybe, Dr. Taneja, maybe from your perspective, what role does each person play in the process of DBS?
So the neurologist, who is a movement disorder specialist, they manage the patient. They manage their Parkinson's disease for a few years, and then they decide that is the patient a good candidate. So there are some criteria that your movement disorder specialist will go through, and they'll decide, okay, yes, you're a good candidate or not. Then the next step I typically do is I let my patients meet the reps. I let them meet all the reps so that they decide. I tell them there are 3 companies. They meet all the 3 reps. That helps them decide. And then they see the neurosurgeon. So once I decide that yes, they are good candidates, then they meet the neurosurgeons. Then if they have any other questions that's specifically related to surgery, then the neurosurgeons will answer those questions. Then after the surgery is done, the patient will come back to the movement disorder specialist and they do the programming. And in between, I think all the reps in my practice, they play a big role. For example, educating the patient. In between, if the patient has any question, if they have any question about the programmer, surgery, or they need any help. So I think it's a full team that gives a good outcome. So typically they say it's 3 steps. You have to fulfill 3 things to have a good outcome, and that is you have to be a good candidate. The surgeon has to put the electrode in the bullseye target, and the programming has to be correct. So if all 3 things are done correctly, then the patient will have a good outcome.
So great. So I think that's an excellent summary. Aissa, maybe you could kind of start out and say, from the industry side, as a rep, how do you see your role, and then maybe let each of you guys kind of answer that question. So what's your role?
Sure. So a large part of our job and our position as DBS representatives, we really call ourselves therapy representatives. So we're consultants for the patients, providing education, walking you through the process, giving you kind of a clear path and description of what the DBS journey and process looks like is part of what we do every day. So we'll visit our movement disorder specialists like Dr. Taneja and say, are there any patients that you need help with? Is there anybody that I can speak to? Do you need any support in your programming clinic? Things like that, as well as keeping everybody informed of what the latest and greatest changes are with our technologies, what Medtronic has to offer. Helping patients who have already had the surgery. Patients will have their own equipment that they need to work with, so we do educations on that. If patients require an MRI scan, we do educations on that. Provide support in any way that we can. So like I said, lots of education, consultation, support, and really just making sure that everybody knows what the latest is and what Medtronic has to offer. So probably in a nutshell, we also, what's really comforting is that when we do these educations for patients, if they do choose to have the DBS surgery, we are also in the OR with them. So I was visiting with Patty earlier in the main breakout, and I said, if you have this surgery, I'll be holding your hand in the OR, walking you through all the steps and kind of reminding you about, this is what's coming next. And so that kind of fully encompasses our role. It's surgical, it's clinical, educational support. So very, very much a well-rounded, position, and we get to provide a lot. So it's a lot of fun.
Andrew, do you have anything?
That was amazing. Yeah, no, I think the tiny bits of yes ands I have is here in Dallas, the person who would hold your hand is actually silencing her phone right now. That's my partner, Melissa Ryan. She's our local sales representative. My particular role, I'm a national manager for digital health at Abbott. And speaking to new technologies and what comes forwards, we actually just launched a new software. So if you, during the breakouts at our little booths, I can demonstrate it for you. It's a capability for you to virtually connect with your clinician for those therapy management sessions. So with your own little iPhone, click a button to connect. If you've ever used MyChart to connect with your doctor on your computer, very similar to that. So when you have your brain stimulator adjusted, you can do it from the comfort of your living room home. So my role has been to help our salespeople bring new technology to market. Previously at our company, I also played a role of biomedical engineer to help develop the software. So in addition to our reps, we have people in science, neuroscientists, biomedical engineers, that like to learn from all of you and what it's like to live with these implants so that we can always make them a little bit better.
Great, Sean, do you, I have a follow-up question for you, but I'll let you kind of jump in there and then.
Well, I think they both explained it well to, new technology and trying to break up some of the differences. The great thing is DBS is an amazing therapy, and education's power. And to Dr. Taneja's point, everybody shares a little bit different experience. I've had 16 years in the DBS world, and to Dr. Taneja's point, she can bring it up to the patient, but where are most patients during that point? That's when they're on the ceiling about brain surgery. And just information is power, and talking to other patients who have gone through it. And that kind of nature, you just want somebody to make a decision right for them. Most doctors bring up DBS as a patient advocate because there's a window of opportunity, and you want them to be well educated. To her point, a great candidate, that's most important to start with. So the timing of it really does matter, but that's between the physicians. But not putting something off to something that could benefit you today. But once you have that information, whatever you do with it, that's the beauty of this. You go on your journey, but as long as you have good information, which Dr. Taneja is a great advocate for patients, making sure they do have that good information. And we have so much great physicians in that community. You all can understand when I started doing this 16 years ago, it was way different on the information and education patients were getting. They were getting stuck in community neurologists, not seeing specialists because there weren't very many. And if there were, it was hard to get them there. So it's really changed. It's a great community to be dealing with Parkinson's. There's so many tools to help you live better. And I'm just lucky to be a part of it. And with Boston, it's been a great place for me. There's some great things that separate some of the different technologies, but they all help patients, and that's a great thing.
Good, so I think each of you at some point has mentioned the word candidate. So let's maybe define that. Who is a good candidate? And so just to put that in context, one of the questions from a DAPS member that was emailed in said, is there an age limit to getting DBS? And then the second question was, I don't really have a tremor. My problem is mostly unsteady gait, which means I fall a lot. Will DBS help me? So let's maybe define, Dr. Taneja, when you have a patient, what are you considering in terms of who might be a good candidate?
So the first thing is that the diagnosis of PD has to be confirmed. The diagnosis of Parkinson's disease has to be confirmed. Your movement disorder specialist has to say, okay, I'm confident this is Parkinson's disease. And in fact, our society, the Society of Movement Disorders, says that every year the diagnosis of Parkinson's disease has to be confirmed and reconsidered and say, okay, yeah, I still think you have Parkinson's. Next year you go through everything and say, yes, I still think you have Parkinson's. So once you're comfortable and say, yeah, this is definitely Parkinson's disease, then the other thing is the response from the surgery is predicted by how you respond from your medication. So whatever benefit you get from your levodopa or the other drug, you will get the same benefit from surgery. So if you have ABC symptoms and they respond well to levodopa, then those symptoms will respond to surgery for the most part. There are some symptoms, there are specifically midline symptoms that may not respond to surgery. Soft speech or soft voice or mood or a lot of postural symptoms, they may not respond to surgery. So any symptom that responds to medication will respond to surgery. So that is the second thing. The other thing is you have to have intact cognition. Your memory has to be good. So your movement disorder specialist will get a memory testing done, which is called a neuropsych testing, which can be like 4 to 6 hour test. But we have great neuropsychologists in the DFW Metroplex. They will do the memory testing and then they'll clear you for surgery. And then before that, so remember I said how you respond to the medication is how you will respond from surgery. To decide on that, we do something called on and off testing, or we call it levodopa challenge. So you go to the doctor's office off the medication, so without taking your medications, you'll be in off state. Then the doctor will examine you, and then you will take the medication and they'll examine you again. So when we do that, the first thing is we establish that are you responsive to medications. The second thing is it helps the physician as well as it helps the patient understand and have realistic expectations. It's very important to have realistic expectations of the surgery. There are times that we've seen that the patient has done really well from the surgery, but they were just expecting something different. Like their voice didn't get better, but they wanted their voice to get better. Everything improved, but just because their voice didn't get better, they thought the surgery didn't help. So that's why when we do the on and off testing, we set up realistic expectation for the patient and for the physician to say this is what will improve from the surgery and this is what will not improve from the surgery. And the third thing is definitely you have to be a good surgical candidate from medical perspective, from your cardiovascular or pulmonary or other issues. So those are the major criteria. So your movement disorder specialist will discuss with you, go through all the testing and say, okay, you are a good candidate. These are the things that will respond to surgery. And most of the time it's the motor fluctuations. Like what will happen is patients will take the medication. The medication will help them for 2 or 3 or 4 hours depending on the disease duration. And the medication will wear off. So when you get the surgery done, you won't have those motor fluctuations. So once your physician will discuss with you that these are the things that will improve and these are the things that may not improve, then you think about it and say, okay, this is gonna help my quality of life, I wanna move ahead with surgery. So
Great, yeah. So I think that helps us sort of define who might be a good candidate. Are there any questions so far from the audience to any of our panel members? Yes, sir.
Could you dilate a bit on, I think you said cognitively intact?
Yes.
Could you expand on that and why that's important?
Okay, so cognitively intact, your memory has to be good. So memory is a spectrum. There's normal memory, then there's some subjective impairment of memory, then there is aging, then there's mild cognitive impairment, and then there's dementia, right? So there's a whole spectrum. People who are demented cannot get surgery done. And then, so because once you do the surgery and you put electrodes inside the brain, specifically at a certain.
And you have a remote control you have to run, right?
Yes, one, you have to run the remote control, and second, if you have baseline memory impairment, and based on which target we decide, your memory can get even worse after the surgery. So that's why we get a proper, detailed, formal memory testing. And then sometimes your memory may be in a gray zone. You may not be demented, but you may not be as crisp as what you were when you were 40 years old. Then that's also the discussion your specialist, your physician will have it with you. So brain surgery, I tell my patient, it's not, when I start talking to them the first time, I don't want to scare them. I say, I'm just approaching this topic. This is something we may discuss more in future. It's a process before we get there. I'm not scaring you. Let's just start talking about it. Let's just start reading about it. The first time I just say, let's just read. We're not doing anything. Let's just read about it. Then I'll say, okay, now you have more information. Let's just meet our reps. We go step by step. So I hope that answers your question.
Thank you.
What other questions at this point? I have more questions, if there are not any from the audience. So, tell me about the surgery, and I've sort of started on this end, so maybe, Sean, I'll start on that end this time. So, one question from a DAPS member was, how painful is the procedure itself? And I realized, you're not the surgeon.
Right.
And I also realize you're not the one who's undergone the surgery. But you're in there, right? The three of you are
The
in
question
there.
is, do you have empathy?
Yeah, so, a couple of things. So the way that we explain the surgery is that the reason you can be awake, the only thing that senses or feels any pain is your skin or your scalp. So what would any, surgeon do to offset that? They would use local and numb it. So you can safely, comfortably be awake from it. Does that mean the whole part of the surgery is easy? No. And we explain that, and we have a patient here that can probably give her explanation, but generally placing the head frame, some centers don't do that. Some centers, even do a sleep, and there's different ways of doing it. So it's a variable question. For awake surgery, which is the most common way that it's done, placing the frame is definitely not something you wake up every day saying put one on, but it can be safely and quickly and comfortably done. Because it's numbed up wherever the pins hold on. And the surgery itself, your bone in the brain doesn't have any nerve endings. So it's very, I don't want to say comfortable, but Aissa's point, we are holding the hands of the patients. We're right there talking them through it. If they're awake, some give some more medication during that. They don't even remember, burr holes or anything like that. But overall, patients can comfortably get through it. But some people have low back pain, some people have this, and the whole team at all the centers really just do a great job of managing the patient and helping them get through it, because really for a 2 to 3.5 hour procedure, not all surgery time, but you're back there, it can help you for the rest of your life. So it's one of those things that, waking every day dealing with Parkinson's is way tougher than, it doesn't make the surgery easy, but it's a tool to help you for the rest of your life. So
Explain that frame that you're talking about.
yeah, so most centers here use what's called a Lexel frame. So it basically goes up and over the nose, and it's square, it's got numbers on it, it's not touching you. And then there's 2 posts in the front and 2 posts in the back. It's still not touching you. So that's where the surgeon will use a lot of lidocaine and numb up 4 spots at the top of those posts. When he does that, he places pins, and those pins tighten all the way down. They hold the head frame in place. But since this is numb, you don't feel that. The biggest complaint is generally the earplugs that give a little bit of tension inside the ears. So I always tell patients ahead of time, listen, that might be the most painful part of the whole surgery. Do you agree?
Yeah, that's probably the most uncomfortable of the placement. The only other additional sensation I've heard is the pressure is like a sinus headache. And that eventually fades because you get used to the pressure. And then when they take the pins off, you feel it again. So it's like having a headache. But again, they can give you some headache medication to help manage that. So from a pain perspective, like Sean said, it's probably more uncomfortable. You'll be in sort of a beach chair position. And so if you have low back troubles, the nurses will give you pillows to help prop you up and make you feel comfortable. But yeah, the brain itself doesn't feel any pain.
Right.
And then when you're awake from stimulation, and I don't know if you were awake, they'll stimulate your brain so you can see, is it working? And then you might feel tingling or numbness, and that's good, so they know where they are, and they can get very, very precisely. This frame that Sean described, or even doctors that use robots, it's all called stereotactic surgery, and they're accurate to within less than a millimeter. They're very, very, very precise. So I like to think of this as more of a procedure than, when you think of brain surgery, you're thinking of a doctor opening someone's head.
Yeah.
They make a tiny little hole. Some doctors even make a super tiny hole. So, yeah, discomfort.
And so
No.
let me add to that. Every time, when I'll see the patient back and I'll ask them, how was it? I've never had a patient complain, oh, the pain was so bad, I
Yeah.
wish I never went through it. Did patient ever tell you that during the surgery? Oh my God, nobody told me. I wish I would have never done that. Did you?
Yeah.
Right? So, I
And
don't
she was
think.
she was fearful and, right? I mean.
Yeah, it took me 2 years. My doctor told me about DBS immediately, the first visit, just to make
excited to get it turned out as
Yes,
quickly as
and
possible,
it
right?
really excites them to see, it's very interesting to see, exactly.
That brings
It's
up
a-
another question, or adds on to it a little bit. I was very anxious, I wanted to get the battery turned on immediately, but there's a wait period, can you explain why there's a wait period?
Okay, so, what happens is right after the surgery, there's gonna be some swelling, there's gonna be some swelling in the brain right around the electrode. So, there are two ways, when we program it, there are two ways of programming. We can either do it where we decide on a voltage, and a certain amount of current goes based on what is the resistance of the brain tissue, right? So right after the surgery, there's some swelling, so there's a certain amount of resistance. But as the swelling improves, that resistance changes. So if we are programming the patient and we are setting a certain voltage, the amount of current that's gonna go changes as the tissue resistance changes. So that's why we say, let's wait for a month, let the brain heal, let the swelling go away, so that then we'll have a constant resistance. So if we set a certain voltage, a constant amount of current will go, so that the change in the resistance doesn't affect. But now we have another way, now we can decide on a current. We set up a current amount, rather than setting up a voltage, we set up a current. In that case, we don't have to wait for a month, we can do it immediately. But for the most, like if the patient is not doing well and they really wanna get programming, we can do it. But for the most part, we let them heal, and then we do the programming a month later for that concept. And sometimes what happens is there's something called a honeymoon period, like right after the surgery, because of the swelling around the brain, because it's kind of a lesion, there's a small lesion during the surgery. So that lesion sometimes helps the symptoms. So some people may have really good symptoms for 2 weeks after the surgery, even if the electrode is off. So sometimes that also happens. So that's why we say, give it a month, let the swelling go away, resolve, let the brain heal, and then we'll start the program. But if somebody's not doing that, sometimes I can bring them back, we bring them back to the programs.
May I ask a question of the recipient, for lack of a better term? How much were you able to cut down on Cinemed?
I was,
Choose you need.
I didn't use cinnamon when I did at the beginning, it would cause severe dyskinesia. I'm sorry. It caused severe dyskinesia, which is the loss of control.
The dancing movement, it's like, you know, the
She
dancing.
couldn't tolerate the medicine.
Oh,
So
okay.
she was starting from zero. She did the surgery, I'll let her explain, but it allowed her to take some.
Yeah, now that, I don't know if you know exactly what the drugs are for, but it's to keep your dopamine levels from decreasing, because you're always gonna be decreasing no matter what. But, it keeps it from decreasing at a rapid pace. So now I'm able to take, Retari and Nupro, which is an antagonist and an anti-antagonist, and they work against each other, but now I can tolerate them. So now my dopamine levels are being held, and I've had the surgery and I'm not turned.
Yeah, I mean, it's a great question. If I'm recalling from the literature, the reductions are upwards of about 50% in
Yes.
some people, right?
Yes.
But it'll depend.
It will depend. So the goal is of the surgery is not to take you off the medicine. The main goal of the surgery is to give you good symptom control, so that you're not yo-yo, right? In that process, if you have good symptom control from the previous programming, and then we'll start going down on the medication. Yes, and 50% we may be able to go down 50%. But in some patients, we may not. Some patients are dependent on levodopa for mood, for non-motor symptoms. Like for mood, they may feel that they feel very depressed or low on low dose of medicine. So then we still have to give them medication. But whatever is just discussed with your patty, we discuss. And then, so that you have to, one thing that's very important is to have the right goal. You and your physician have to be on the same page on what your goals are. You let me know that your goal is, you wanna decrease the medication. And it also, so in DBS there are 3 targets in the brain. So when we are doing the surgery and I have to decide which is the target, we also have to see what are the symptoms that I need to control, what are the goals, so that also helps.
And to that point, sometimes the side effects, even if you get a 15 to 20, which is on the lighter side, that's usually that 15-20 that's putting you to sleep in the middle of the day, or you're dealing with those side effects. So dropping them down even just a little bit can really help your functionality. And I always tell patients, it doesn't, unless that's your goal, which some patients it is, and they go to a different structure for that, but if you end up being on a similar amount of medicine with the stimulation, you're gonna be doing that much better. You're gonna be doing so much better that you don't care if you're taking medication. It's a good thing. You generally wanna drop, but if you need both, then that means because you're doing that much better. Otherwise, you wouldn't be taking it. You'd drop it down. So I was, the doctors are experts at managing that. Sometimes that takes some ebb and flow over the first few months. It's not right away, for sure. But
Having the right expectation is very important.
Mhm.
That just dictates your success to surgery. Like, you may be someone who may not be able to decrease your medication, right? Maybe. And then, but if that is your goal, you have to let the physician know. And then if they feel like, no, in your case, I may not be able to decrease it because I need it for this reason on you, then the physician will let you know, and then you can decide, okay, do you still want the surgery? Does that make sense? So having the right expectation and right goal is very important.
So I do want to ask, Aissa, are there any side effects? So the surgery is not painful, maybe some pressure. Are there any side effects after a surgery or from DBS? And then one person wrote in, what is the recovery time after surgery?
So we talked about a little bit about the surgical procedure and the fact that most patients will be awake during surgery for the purpose of testing your symptoms. So we'll want to look at your tremor, test your rigidity in the OR. At the same time, we're also looking for potential side effects. And what that might be is you have a target structure in the brain that we are trying to stimulate in order to reduce or alleviate Parkinson's or tremor symptoms. But there are surrounding structures to those targets that can create unwanted side effects. So there are intraoperative side effects like muscle contractions, facial pulling, slurred speech, visual field changes, things like that we can visually see, that we can test for, asking how you're feeling. We talked about maybe some paresthesias, which are a good thing, but if they're persistent, meaning that they don't stop, that's not so much a good thing. So things like that we look for, like I said, intra-op side effects that we want to eliminate before we close up those holes in the head and say, this is the spot in the brain that we like. Post-op side effects could be some similar stimulation type things, but what's great about the latest technology is that the equipment and the leads that are implanted in the brain are so advanced that a lot of times we can steer away from those unwanted side effects. So that's part of the latest technology that Medtronic does offer. Really being able to shape the stimulation field so that we stimulate that targeted point that we're aiming for without affecting those surrounding structures that can cause those unwanted side effects that I mentioned earlier. And then the second part of the question was?
Recovery period.
Recovery period.
Thank you.
So,
I couldn't
thank
remember my
you,
own
Andrew.
question.
Yeah. I know, I couldn't either. So, like Dr. Taneja mentioned, the physician would really like to give patients about a month to reduce that swelling in the brain. Get you back to baseline so that when they do turn the stimulation on, you are at a kind of normalized brain tissue environment, essentially. One of the biggest things after that cranial surgery, as well as the device placement in the chest, is remain free from strenuous activities, keep the incision areas clean, clear of pet dander, wrist infection, hats, baseball caps, things like that. We don't really, the surgeon's office will give you kind of a more clear cut, we want you to sit still for X amount of time, but really we say, take it easy, don't overexert yourself for a few weeks, essentially.
So can I ask?
Yeah.
So typically if a patient is working, how long do you tell them, like, plan to have 2 weeks off from work, or how long
Right.
from work should they apply for, like, when they start planning? How many days off the work
So,
Well,
for my working patients, like?
right. I mean, probably a few weeks, but if their
2 weeks
stimulation
off.
isn't turned on.
No, just to
Yeah.
recover from the surgery.
Mhm.
Just to recover, how long will it take them to recover from the surgery to be able to go back to work? Because that is what a lot of my
Right.
patients
usually
ask.
we're gonna,
Few weeks.
a lot of the other doctors will generally push them further than that. The reason why is, every patient's different. So if you say, oh yeah, you're gonna get back to work in 1 month, I've had patients go back to work in 2 weeks, but that is very, very rare, and I'd never recommend it.
So a month
Because,
off work.
so 6 to 8 weeks is kind of from strenuous. You're gonna be walking the day of surgery with help. They want you moving for clots and stuff like that. You're not in bed, sitting at home for a week, like they want you.
It's not respite
They want you
recovery.
moving safely. You can take your medicine after your surgery, but like you're explaining, you can have that short period, but you wanna shoot. If somebody's asking you, when can I get back to work?
Because they want
Most
that
doctors push it way back, and the idea is, if we can, it's tough to push back, it's easy to pull up.
Easier to pull forward.
So if they're good in 6 weeks, you can move it up. But when somebody has it in their mind, because if you've seen, if they end up being one of those tricky patients, it's not good. I've seen patients have very nice outcomes. They go back to work too soon, get in a stressful environment. As you know, Parkinson's, everything, it only hits you 25 different ways. But they go backwards, and it took them 6 months to get back. So as soon as you tell a patient that, most of the time they hit the brakes.
And how long before they can start driving?
That's
Say last time.
patient by patient,
I
generally
know.
because that's so variable. I mean, you have some patients that, she wasn't driving before surgery. Did you wait till after the second programming or
Right
first?
after the first programming, yeah, I started driving after the first programming.
Okay, so she was, that was, 3 weeks after your, 3.5 weeks, almost a month after her surgery. So she's an exception to the rule, that's Christy over here. But,
Accelerated student.
But, no, she hadn't taken her daughter to school in probably 4 years, yeah.
Oh, wow.
Yeah.
And she went to school 2 blocks from my house. I saw that, I shouldn't have been driving that up to then.
Yeah.
Amazing. So I think to that point, I think with both questions, with work and driving, what is your baseline? What was the patient doing beforehand? If you're wearing a hard hat to work, it's a lot different than if you're sitting at a computer working from home. And these days, so many people are working from home, so I think it's just extremely variable for both questions.
He said not to play baseball.
Yeah.
I said,
Good advice.
I said, all right.
Okay, this is a weird question. I keep hearing this thing, have it done at the optimum right time, but don't wait too late. So how do you know that you're in that optimum time?
Your physician will help you decide. So when
Okay.
you're in that window, your physician will tell you, hey, I think you're a good candidate. When they start talking to you, that's when they think you're a good candidate.
Okay.
And then, so they'll say, yes, yes, there is a window of opportunity for the surgery. That's why they say, do not take surgery as a last resort. Don't
Right.
say, I still have patients that will come and tell me, I don't think I'm there yet. Oh no, I'm not that bad. When your physician is approaching the topic, that means your physician is thinking you're a decent candidate. Because of course, there's some other workup that needs to be done. But they're thinking in their mind, yes, you're a decent candidate. Let's just start talking about that. So when they're talking, they think you're in the window. And once all the workup is done, then you're a good candidate. The window, the reason there's a window is, what if, like I said, if you have memory issues, you will not be a candidate. So you may have very good memory now, but if you want to wait for 2 or 3 years, maybe your memory is affected. Then I'll say, I'm not sure if you feel a good candidate now, or there are other things. Now, some people do well, but then they get very depressed 2 or 3 years from. Sometimes you may have other cardiac issues because it's a surgery. Some general anesthesia is needed. So you have to have good general health condition. And I've had patients that 2 years later started having AFib and then had something else. else, and then some GI issues, and then was not a surgery candidate. So you have to be healthy as well, so that's why there's a window.
What a lot of the movement disorder will say is, you know, when you're chasing your good time, when you're good most of the day, surgery doesn't. But since DBS gives you what your best on medicine is, that's why if you wait 2 years, your best on medicine is gonna look different, and that's what DBS gives you. So it's one of those things where that's where the experts, I mean, truly, they're advocates for you. They're like, oh, I see you struggling and chasing your good time. I know this will turn back the clock and help that. And they know if you do wait those 2 years, you absolutely can, and we've seen it. But at the same point, would you go back and tell I know the way that it worked out, but would you tell your person 2 years ago, oh my gosh, why did you suffer for those
Yeah,
2?
absolutely.
Yeah, so that's somebody that, and I know, you know, with my former company, I mean, that was on all of our stuff. It was like 90-some-odd% wish they had done it sooner. You know, it's one of those things, but to ask those, that's a great question. Your doctor will definitely help you, but if they brought it up, they didn't bring it up lightly. They see you fluctuating, and they know you're gonna go from 3 doses a day to 4, and they're gonna have to keep tweaking those meds, so they're like, okay, if I can intervene with something that's gonna help them the rest of their life, I can have a powerful tool here, and then they can do what they do best with the thing.
Unfortunately, my doctor's got your.
Well, there you go.
So, and having a good, I think the theme, right, that we're probably trying to always encourage is communicate, talk to your doctors, make sure they know all of what you're feeling and dealing with, right? Because like Sean said, Parkinson's hits you from 25 or more different directions, and knowing how you're doing on all those dimensions is helpful for your doctors to know how good will you do with the stimulator, or what can we do with medications, right?
Also, the other thing is if you talk to your doctor and you decide this, yes, you're a candidate, and you say, no, I'm gonna do it 2 years later, rather than doing it, if you think, and I tell this to my patient, if you think, yes, I'm gonna get it 2 years later, then why not do it now and enjoy the benefit now, rather than waiting 2 years later? That's a different story if you say, hey, I'm never gonna get it done. I respect my patient, every person is different, I respect if they decide that, and I said, if my patient says, I'm not gonna get it done, I said, yeah, that's totally fine, I still want you to get the information and make an informed decision. If you still decide you don't wanna get it done, I'll respect your decision. But I want you to be informed and then take the decision. If you decide you don't wanna get it done, that's fine. But if you decide, I wanna get it done, but maybe 2 years later, then why not do it now and enjoy the benefit from that? Because you know you're gonna get better 2 years later when you do the surgery. Why not now, and then you're healthier now?
To her point, somebody that didn't want to get educated or hear, like I said, on the ceiling, and this is, you know, many years ago, and then they have some other health issues, and they come to them, and they're really struggling, and they come to these doctors, and it's like, I'm sorry, the window's kind of closed. And in the past, getting from the community neurologist to them, who could at least inform them, what you do is but not having that information, or making a decision that could help you the rest of your life, if you at least don't have that information, or good information that all of us share, that's a really tough thing. But as long as you have it and you make your own decision, everybody's good. But it's when they make that decision, then when they really hit a wall, they come and say, okay, help me, and it's like, I'm sorry, I can't. The doctors and myself who have seen it, it's one of the hardest things. When you're an advocate for the patients and you see that, it's like, it's tough, because, you know, medicines will continue to help, but it's gonna, you keep losing those neurons, it's gonna get trickier over time.
How long does it take to get implanted from the time you say, yes, I wanna do this, to the surgery?
I tell my patient, I tell my patient it's a 6 month process, but you know, every patient is different. My patient, I may get a new referral that everything has been done and they're coming to me for DBS. I still tell them, I treat my patient, I don't treat the disease, I need to know you. We wanna be on the same page, like, coming back, expectations. I wanna be on the same page as you are on what our expectations are. I really tell them it's a 6 month process by the time, because you'll meet me, I'll do my evaluation, I'll see if some medicine needs to be tweaking, we'll talk about it, I'll do on and off testing, then you'll see it, then you'll meet the reps, then you'll see then you'll do neuropsych testing, and you'll see the surgeon, and the surgeon will give you a date. So I tell them, especially my patients that get worried, I say, if
say, your range of 3 to 6 months, like the quickest is probably on the 3-month side of things, 6 months, because again, getting to know your movement disorder specialist is very important. But again, depending on where you start the clock, if you already have a movement disorder specialist and they are referring to the surgeon, then maybe you'll be on that closer side. But doing the workup, knowing how well you will succeed with the surgery, understanding that on-off testing, doing the memory testing, all that scheduling, right? Sometimes maybe your schedules are busy.
Yes, some people
So
don't wanna get
that's-
it done during holidays.
Exactly.
They wanna talk to their family member, or
Yep.
they wanna talk to their kids who will come during holidays, so.
Precisely.
Yeah,
And here in Dallas, Dr. Nader Paradian recently joined UT Southwestern. He's an amazing world-renowned functional neurosurgeon, and he's really building that program to be as efficient as it can be. So I know he's really excited to have people in the community ready to come and have their evaluations. So he's a great person to meet through this process.
Yes, sir.
Acknowledging that each patient is different, what would you say would be a typical upper age limit?
They've done surgeries as much as 82 and 83 I've seen.
Yeah.
So there's no, there's a chronological age and there's a health age. So if you're doing well and you're a perfect candidate, as long as as high as 82 and 83 I've seen.
Yeah.
Can I ask a follow-up? How much does it cost? And how do you help people sort of navigate that? Again, acknowledging you can't give me,
We can help.
Yeah.
a particular
So let
answer,
me
but.
tell you this thing.
Yeah.
The simplest answer I can give you is for my Medicare patient and majority of the patients, I've never had a single patient who couldn't get the surgery done because of cost. Yes, if they have absolutely no insurance, like if they don't even have Medicare and just no insurance, that's a different story. But as long as you have some kind of insurance, Medicare or supplemental or anything, I've never had any patient not be able to get surgery because of cost.
Each of our, I don't want to speak for both of you, but I think each of our companies all have charitable foundations. So for someone who has absolutely no insurance, they can apply for help to get one of these devices. I mean, we as a medical device company have all put so much effort into this therapy. We know it works really well, and we don't want anyone to have any barriers. Medicare completely covers the procedure, and most private insurers follow what Medicare will cover.
And there's only a couple right now that none of the DBS neurosurgeons take. It's very rare to find that. And, but it's been well covered for 25 years. If a patient has a supplement, generally a secondary, I've heard almost next to nothing out of pocket, which is amazing.
Yeah, so in those cases, like I said, it's a process of 3 to 6
We don't
months.
get complaints, and we would, and the doctors would, if it was an issue, but it's very well covered, and if there are some barriers, to Andrew's point, there's a lot of support to help people in certain situations.
Thank you.
So maybe a follow-up to your question about how long, once you decide, okay, I want to do this, you kind of settled on 3 to 6 months. Now you have the surgery. How long after surgery before you kind of are finely tuned, or you kind of maximized out the benefits?
So 1 month after the surgery is where you will have the first programming session, and that is called mapping, because and what happens in mapping, and that's a long session. The mapping is typically done in the off state, because during mapping, what we're trying to do is we're trying to test each contact of each electrode and see which contact gives you how much benefit. So we start from the lowest voltage and we start going up, and say which contact gives you the best, a certain symptom control. It could be tremor or slowness or stiffness, and at what voltage and what side effects does that contact do. So we test each contact. So it's typically 2 to 3 hour long session. We call it a mapping session. And at the end of the session, we will give you a certain programming. Sometimes I'll program both the sides, or sometimes I'll only program one side because I want to see what benefit and side effects you're getting. So I typically tell my patient 3 programming sessions. So first is when I give you initial programming. Second is when you'll come back, we'll just do something. Sometimes even second is it. So 1 month difference, second programming is it. max like 3 programming to really fine tune you, and then I'll see the patient 6 or 9 months later. So then 3 programming, and then if everything goes well, then they come 6 or 8 months later. So that's it.
Anything to add? I mean.
I'm curious if you've ever, with patients who have access to inpatient rehab, and I've read, some papers, because you already are on I think a very nicely efficient schedule, and some of the papers out there show with inpatient rehab and programming, more frequent, quick checkups, the shortest time they saw kind of stable effect and stable medications was in that 6 to 8 weeks, so similar to you, in about a month or 2.
Yeah.
So, it's, again, gonna be, I think, individual to the person, how well they respond. And I think it's important to remember, these devices are a brain pacemaker that essentially give you electric levodopa. So the doctor also has to look at how the two, medications and the electricity, work together. And depending on if you're trying to adjust the medications, some doctors only want to change one thing at a time. Let's see if it's the electricity. No, if it wasn't the electricity, let's see if it's the medications. And so that might be 2 separate visits, right? So it's important, again, to remember you have 2 things that your doctor's balancing for you.
This hasn't been addressed yet, you just briefly mentioned doing programming one side or the other. What if a person only has the one side? Would you go ahead and implant both in case in the future they need to have both?
So you mean for DBS electrodes on both the sides?
Right. I had both done at the same time, but I've heard some people having only one side
Yes.
done.
So I have patients, so like Parkinson's disease is typically, it has an asymmetric onset, right? It starts on one side, and the side that it starts on typically is worse than the other side. So I've had maybe a handful of patients where the DBS was placed only on one side because they had more symptoms on one side of the body, right? So that is possible, yes, that is very possible that we do DBS only on one side, if one side of the body has predominantly much more symptoms. So that's very possible. But what happens is, as the disease progresses, just nature of the disease, both the sides will be affected. And when both the sides are affected, then later on, we can do surgery on the other side, right? But sometimes, and that's very reasonable, that's very doable, and that has been done. But the reason sometimes, in majority of the cases, both sides are done together is because the disease does affect both the sides. And when one side is done and the other side is not done, sometimes it gets complicated to manage their medication, because now I have to give them medication only for one side of the body, but not the other, because other is very well managed on DBS. So because that can happen, and also majority of the Parkinson's patients do have bilateral symptoms. I mean, it's different on both the sides, but they do have bilateral symptoms. So majority of the time, the electrodes are placed on both the sides together. But definitely in cases we've done one at a time, and then years later, when they have significant symptoms on the other side, then we place electrodes on the other side.
And all of the devices that are out there have the ability to have 2 extension wires. So sometimes the doctor, even if they're only putting in one electrode in the brain for now, because that's the worst side to treat, they might put the 2 extension wires in and then connect in the future a future brain electrode. So there's options in terms of how the order of the surgical procedures, the brain part or the battery part. Once the battery's there, they can always add an extra electrode.
Like I have a patient who did really well for 5 years with just one side,
Mhm.
and then in 5 years later he has started having symptoms on the other, but he did so well on one side that as soon as the symptoms came, he's like, okay, I'm ready for my second side.
You didn't wait for 2 years.
What?
You did not wait for 2 years.
He did not.
You got it right away.
Yeah.
Well, we are getting close to 1:30, which is sort of our stop time. Is there one last question maybe before I close this out? Okay, well, I want to say thank you to our panelists. These guys are competitors in the space, but I think you'll agree with me. It's been very informative, very collegial, so I'm grateful for you guys participating and hopefully sharing a lot of valuable information. much, and let me just.